So, good afternoon, friends. It's a great pleasure to welcome Dr. Rishi Thakre on the awesome group today. And as you must have seen the slide which I was sharing with you, which run the qualifications and work experience of Rishi Thakre. He brings us more than 20 years of experience of neonatology on board. And it's a great pleasure to have you, Rishi. Please go ahead with your deliberation.
Good afternoon to you all. Indeed, it's a pleasure and a privilege to be amongst you all today. And thank you, Dr. Savar, for this opportunity. And let me share with you in this presentation the clinical insights into management of respiratory distress syndrome. The story begins in the delivery room where a primee at 30 weeks of gestation is admitted in labor with no prenatal or medical risk factors. The prenatal ultrasound shows a weight of 1.2 kg. There are no congenital anomalies and the Liker is adequate. And your colleague asks you, since this is going to be a preterm and the immediate concern at the time of birth in the first few hours would be that of prematurity related complications in the form of respiratory distress syndrome, what would be the best way to treat RDS? And he asks you, which would be the best option? The surfactant, use of non-invasive support, use of mechanical ventilation, or none of the above. And if you have given D as your answer, that is the correct answer. And let me explain. The best way to treat RDS is to prevent it. And today we do know that if time permits, with babies of lesser weight and lesser gestation, ideally, if the facilities do not exist or you are not well versed with specialized newborn care, the best way would be to have this mother delivered in a tertiary care settings where the facilities are available. However, till that time, what else can you do that will help prevent develop an RDS from taking place? And that is by means of giving prenatal steroids to the mother. This is a simple, effective, low-cost, evidence-based intervention which has been known to prevent development of RDS. And it is today recommended that all mothers with threatened preterm labor, less than 34 weeks of gestation, should be offered a course of steroids, which is administered intramuscularly. And the only contraindication for prenatal steroids is a mother with suspected chorioamnionitis. Mind you, I am talking about a course of steroids and not a dose of steroids. So we are talking about course of steroids that would be 2 doses of Beta-methasone or at least 4 doses of dexamethasone prior to the delivery. Having said that, if you see the literature, you would find that there would be a lot of suggestions that Beta-methasone is better. Simply because we do know that dexamethasone has an effect on the growing brain, and long-term neurological concerns are the ones which made Beta-methasone prefer over dexamethasone. However, in our country, the formulation of Beta-methasone which is available is different from the one which is available in the West, and therefore the recommendations for using Beta-methasone as a superior to dexamethasone does not hold true, and therefore in our setups dexamethasone would be a more appropriate and the drug of choice when it comes to mothers to be given prenatal steroids. There is growing body of literature to suggest that why not use it in late preterms, babies born at 34 weeks of gestation, simply because they also are at risk, though it is a minimal risk for developing RDS. Well, the literature today does show that the only advantage that appears to be would be decrease in the incidence of transient tachypnea of newborn with the cost of increase in the risk of developing hypoglycemia. And there are always concerns about absence of long-term data. And therefore, for babies delivered beyond 34 weeks of gestation, using prenatal steroids for preventing respiratory distress syndrome would not be considered today as a standard of care. Now, why are we so much concerned about use of steroids? Simply because the benefits go beyond the lungs. And in the preterm, we do know that if we have to have a single intervention, which will give you a sort of umbrella of protection against the RDS, PDA, IVH, NEC, mortality, and in terms, decrease in the duration of hospital stay, decrease in the risk of hospital-acquired infections, and lesser cost, it is the simple course of prenatal steroids to the mother. And Government of India did come out with operational guidelines telling us that today, even at the periphery, the use of prenatal steroids is considered as standard of care. Now, many would be wondering, in this era of surfactant, why am I harping so much on use of steroids? Well, the answer is best reflected in this trial where we have two groups, and the one group received maternal corticosteroids and the other group did not receive maternal corticosteroids. And look at surfactant being given in both the groups, but the one with no maternal corticosteroids ends up with more complications and more risk of mortality, telling us that irrespective of whether postnatal surfactant is available or not, there is a synergistic effect and added benefit of using prenatal steroids as our first weapon for management of RDS prior to arrival of this baby. And therefore, surfactant should not sway us away from using steroids. Further, if you look at the cost of steroids, is hardly few rupees, not even 50 or 100 rupees, versus the cost of added use of surfactant, which will run into few thousands. And therefore, steroids today is the potent weapon to be used first in our defense against development of RDS. So the first lesson for the clinician is that we must advocate, support, and promote use of single course of steroids for all threatened preterm labors at all levels of healthcare, irrespective of the availability of facilities or not. Having said that, the mother receives a course of steroids and 2 days later, a male baby is delivered and it establishes cry in the delivery room. So what are our priorities in the delivery room? A, early skin to skin contact. B, delayed cord clamping. C, possibility of use of prophylactic surfactant. Or D, consider using prophylactic CPAP in the delivery room. Mind you, this is a preterm, very low birth weight, and who has established spontaneous respiration and cry and is not in need of resuscitation. Now, the key priority remains that if you look at the literature, babies who are preterm, to a tune of almost 30 to 40% end up with hypothermia. And we do know that there is a U-shaped curve when it comes to hypothermia in terms of morbidity and mortality. The single most predictor for outcome of newborn is temperature at the time of admission, which starts right from the delivery room and throughout the course of resuscitation. The studies have shown that there is a dose-response relationship between the degree of hypothermia and the degree of morbidity and mortality. And therefore, today, the hypothermia is not because of lack of equipments. It is more because of our ignorance and our concern, simply because being a preterm, we are all concerned about resuscitation, forgetting that the ABCD in the newborn takes a very high priority in terms of focusing on T rather than ABCD. For we do realize that more than 90% of the newborns would have established spontaneous respiration and cry. What do we do know? Studies tell us that for every degree drop in temperature below 36.5 degrees Celsius, the risk of mortality increases to a tune of about 28%. So even before our battle against respiratory distress syndrome has begun, we have simple low-cost interventions which can happen in the delivery room, and that is early skin-to-skin contact if the baby is spontaneously breathing, and this is applicable for babies beyond 30 weeks of gestation. And if we have a preterm who is less than, say, 30 weeks of gestation, then we would need a combo strategy of using a cap, a servo control, a plastic bag, having a warm sheet, and so on and so forth, and a warm gas during resuscitation. If there is one thing that must be done for all preterm resuscitations, and that would be to record temperature prior to leaving the delivery room. This is a simple, low-cost quality improvement intervention which will mark the care that we are being offering, simply because we do know one of the triggering thresholds for RDS is uncorrected hypothermia, in addition to the base of prematurity. Why are we so much harping today on these two interventions, which are non-invasive, simple, but under-recognized, underappreciated, simply because they have no doubt short-term implications, but also long-term implications. And the second underutilized intervention in a well preterm, irrespective of gestation, at the time of birth is delayed cord clamping. What is expected of us is masterly inactivity in the first minute of life. And just holding the baby, keeping the baby in skin-to-skin contact with the mother, and if required, doing a suction is all that is required in the first minute. And the cord would be cut at the end of first minute, irrespective of the gestation, if the baby has established spontaneous respiration and cry. And this is simply because we are giving an edge to this preterm by offering improved cardiovascular stability in the form of better transition to a blood pressure, increased blood volume, decreased need of transfusions, decreased risk of developing intraventricular hemorrhage or developing NEC, which otherwise would be coming as are one of the complications when we start managing these babies with RDS. And therefore, these two simple interventions are worth putting all our efforts on. What about use of prophylactic surfactant? When we were trainees, we were recommended to use surfactant for all babies less than 30 weeks of gestation. Today, we do know that this procedure is invasive, not cost effective, and not all babies would end up developing RDS, and there is increased risk of death and or bronchopulmonary dysplasia, and therefore today using prophylactic surfactant is not considered as standard of care. What about prophylactic CPAP? Again, an intervention which causes more harm than benefit, and therefore today prophylactic CPAP and prophylactic surfactant have no role. If this newborn had not established spontaneous respiration and would have needed resuscitation, we would go on for thermal combination strategies, use positive pressure ventilation with low oxygen to begin with, and consider addition of PEEP, which I shall come back again later on if there is a need for positive pressure ventilation. But the key role remains that we must document temperature as we leave the delivery room, or for that matter, as the newborn arrives in the nursery for further care. This is a very important statement, which came way back in 2005 by Dr. Alan Job. He said that there is perhaps nothing more dangerous for the preterm lung than an anxious physician waiting with an endotracheal tube and a bag, telling us that becoming invasive is today not considered as standard of care, simply because we would have an urge to do something in the form of intubation for such small preterm babies, realizing that half of them would have established spontaneous breathing on their own and would in fact be damaged by our intervention of routine intubation for these very preterms. And let me just share with you this animal study video, which is an electron microscopy of the neonatal lung. And it tells us on this side is resuscitation, which is happening with just the use of PIP. And you would realize that there is air which is there mostly in the airways, and less of peripheral air alveoli are getting involved. Compared to here, if you see an addition of PEEP leads to more recruitment of the alveoli, and therefore today the standard of care would demand that if we are giving positive pressure ventilation, it would not be only with PIP, but it would be with PIP with PEEP, and that is possible if we are using a T-piece resuscitator and not a self-inflating pad. And this simple intervention today, therefore, would give you consistent delivery in terms of opening of the lungs, in terms of delivery of consistency, in terms of pressure and titration of oxygen. And therefore, positive pressure ventilation will always be with PEEP in the delivery room. We do know that even few breaths of PIP that we would give in the delivery room would initiate an inflammatory cascade, which would lay down the foundation for not only a respiratory distress syndrome, the newborn, but go on to develop into a chronic lung disease. And therefore, in babies who have spontaneous breathing but have respiratory difficulty in the delivery room, we would administer PEEP without administering PIP by means of a TP's resuscitator by just holding it face mask, delivering a continuous regulated flow of gas, which will help distend the alveoli and help decrease the work of breathing. Delivery room CPAP is a preferred modality and not prophylactic CPAP that we said in babies who would not have had respiratory distress. Remember, prophylactic CPAP is different versus delivery room CPAP. Delivery room CPAP is for babies who develop increased work of breathing, but the key point is the baby must have spontaneous breathing. Now, when we talk about babies of lesser weight and lesser gestation, traditional thinking was that we would intubate such babies routinely, but we do know that half of these babies would have good spontaneous respiratory efforts. And if we look at comparison in terms of both the risk of death and the risk of complications between the two groups, it tells us that it is very difficult to justify today of routine intubation for preterms irrespective of the gestation, and therefore it has to be baby specific care in the delivery room. Use PEEP along with PPV if there is a baby who is having difficulty in breathing. However, if the baby is breathing well, just apply PEEP, and that is what today the standard of care would demand. The key issues today remain that majority of the delivery rooms today do not have compressed air. We must realize that TP's resuscitator requires air and oxygen. And if you don't have compressed air, we would be running the TP's resuscitator only on 100% oxygen, which defeats the purpose. It may generate pressure, but it will expose the newborn to high oxygen concentrations, which is not desirable. Further, oxygen blender is the blunder today in the delivery room simply because, again, this equipment is missing both in private as well as in government sector. And without an oxygen blender, we would not be able to adjust defined oxygen concentration, which will again defeat the purpose of resuscitation. And last but not the least, use of TP's resuscitator, we said, is the preferred choice for ventilation in the newborns who do not breathe. And again, not all delivery rooms have access to TP's resuscitator. Therefore, with these due concerns in mind, we must realize that there is a scope for improvement if you want to catch up in terms of quality care. So what are the lessons we learned from the delivery room? Do not neglect thermal care. However good we may be in the care of A, B, C, D, if hypothermia sets in, it's a ball of no return. If the baby has spontaneous respiration and cry, perform delayed cord clamping and ensure early skin-to-skin contact. There is no role for prophylactic surfactant or prophylactic CPAP. If there is a need for resuscitation, use room air with PEEP with the bag and mask ventilation. And if facilities exist, you must initiate delivery room CPAP in babies who have difficulty in breathing in the delivery room. So this baby was shifted to the nursery, and you provided what is now today considered the foundation of newborn care, and that is TOPS. Now, I don't know how many of you are aware about TOPS. It is temperature, oxygen, perfusion, and sugar. If you are able to maintain the TOPS of any of the newborn, sorry, half the job is done. So as you stabilize, you are looking at the baby and you want to predict what is the risk of this baby going to develop an RDS. Would you do a shake test? Would you do a Silverman-Anderson score, also called as SS score? Would you do an X-ray test to predict development of RDS, or do you need an ABD score? When we were postgraduates, we were told and taught to do a shake test. However, that is now anecdotal, and their utility in clinical practice is hardly any. So What about using an X-ray chest as a predictor? We do know that X-ray chest is not a good way by which we would be able to A, identify the severity of the disease, B, predict the development of disease, and the X-ray picture lags behind when it comes to clinical picture. And therefore, X-ray is not a good way by which one would initiate any management. And I will come to that again, how we could go clinically in terms of our interventions also. And obviously, you don't need an ABG to identify distress from failure. The single simple bedside clue to you to predict development of RDS is, in this baby who is otherwise asymptomatic, to look for periodically upper chest retractions, lower chest retractions, xiphoid retractions, dilatation of the nostrils, and the grunt. These 5 bedside clinical parameters assessed periodically in an objective manner will help you define the gradient of respiratory stability or instability. Mind you, this is not a one-time assessment, but an assessment which should take place hourly basis, which will tell you what is the trend of the course of this baby. And based on the score, one would be able to identify the severity of respiratory distress. Just 2 practical caveats. A, always interpret the score looking at the trend, not in isolated value. And B is interpret the general status, that is sensorium of the baby while you interpret the score. For example, a baby who is gasping will be in respiratory failure, but will underscore simply because it has left its energy and can't even breathe properly. And therefore, a worsening sensorium is an alarming sign. An improving score tells you there is recovery, but a worsening sensorium, irrespective of the score, tells you that it is a baby who is gasping for life. So at 1 hour of age, this baby's Silverman-Anderson score came to be 3. What would be the best strategy for care for this baby? Start oxygen, start CPAP, intubate, ventilate, and give surfactant, or consider use of humidified high-flow nasal cannula. So many of us prior would have intubated and ventilated these newborns. And we do realize that ventilation today is a procedure which is associated with its own complications, and there is always a risk of barotrauma, volutrauma, atelectotrauma, and biotrauma when it comes to mechanical ventilation. Today, the trend is how could we best ventilate without intubation? And therefore, today the way forward is to use a non-invasive respiratory support in a baby who has spontaneous breathing. We would give a flow of gas which is humidified, which is warm, and which is under pressure, which will help open up the alveoli where the primary pathology of RDS resides with. And what do we do know that today there is growing body of evidence which says that use of CPAP should be the primary modality of respiratory support in babies with respiratory distress syndrome, simply because it decreases the need for assisted ventilation, it decreases the duration of mechanical ventilation, and it significantly reduces mortality. Mind you, 1/3 of those babies who would be on CPAP would escape need for surfactant. And therefore, we have dual advantage of using non-invasive respiratory support in the form of CPAP as our first line of intervention when it comes to babies with RDS. We do realize that CPAP is a safe intervention, except for the clinical concern of nasal trauma, because this will require meticulous monitoring. Distension of the abdomen because of the flow of gas is common, which is physiological. Risk of air leak practically is none today, simply because many of the times we have surfactant being administered to these babies, and there's no additional risk of increase in the incidence of any of the comorbid factors when we consider using CPAP as our first line of therapy. Having said that, if we have this baby who is on CPAP, and we have this baby who is on CPAP, look at their color, look at their comfort, and look at their retractions. you would soon realize that this baby, though has a color which is pink, is comfortable. There is hardly any increased work of breathing versus this baby where there is increased work of breathing despite being on CPAP, telling us that there would be some babies who would not get supported on CPAP. And we would be able to predict which are these babies. If you have a score of 7 or more after 2 hours of initiating respiratory support or on CPAP, your oxygen requirement continues to be more than 50%, it's very likely that this baby is going to fail on CPAP. Further, a whiteout on an X-ray tells us that this is not a good candidate to be supported by means of CPAP. And at any time during this course, the baby develops apnea or there is associated comorbid features of sepsis, PDA, IVH, or an hypotension, you would end up with this baby failing on CPAP. But the point again I drive back is a history of adequate course of antenatal steroids is one of the best ways by which we can help mature the lungs of this preterm. And no or inadequate antenatal steroids again puts a baby at risk for not getting supported by non-invasive measures. And the advantage of using any non-invasive form of respiratory support is not only in terms of RDS, but decrease in terms of both development of mortality or development of chronic lung disease. But this is a simple low-cost intervention which is known to work. So when would you consider start CPAP in such babies? Anytime a preterm develops respiratory distress in the first 6 hours of life and has a Silverman score of 3 or more, or needs an oxygen requirement of more than 30%, one on clinical grounds alone would initiate CPAP as our first line of support. Mind you, do not need an X-ray chest to start CPAP. Having said that, when would you consider giving surfactant to this baby? Now, we said we have 2 arms of using surfactant for babies with RDS. One was the prophylactic arm for prevention. And obviously, we gave reasons why prophylactic surfactant today is not standard of care. So you are left with treatment of RDS, which could be early as first 2 hours of life, or a rescue in the first 6 hours of life, or late rescue in the first 48 hours. What does it mean? If you see a baby beyond 48 hours of life, use of surfactant thereafter is beyond what you can say the science, or it would be taken as an off-label use of surfactant. So the options today for us are to use early or rescue surfactant, and therefore in the management of RDS, what matters is the timing of giving surfactant. We don't want under or over use of surfactant because it's a costly drug. And for all practical purposes, we knew when to start CPAP. And when this baby needs an oxygen requirement of 40% or more, or needs a CPAP support of 6 or more, we would end up giving surfactant. And obviously, any baby who does not get supported on CPAP needs to be intubated anytime, either for resuscitation or for need of ventilation. One would administer surfactant early. And we do know that earlier in the course of RDS, we would give surfactant. More is the benefit. Natural surfactants are to be preferred over synthetic surfactants. And the early surfactant therapy gives you a lot of benefits in terms of lesser incidence of air leaks, pulmonary interstitial emphysema, neonatal mortality is reduced, and chronic lung disease is also reduced. And therefore, the question remains is, should I start CPAP and then give surfactant, or should I give surfactant and shift over to mechanical ventilation? The standard of care today is to use what is called as Insure technique. You intubate, you give surfactant, and you extubate back to CPAP. And therefore, you do not shift over from your primary modality of respiratory support, even if surfactant is available, especially if the baby has spontaneous respiratory efforts. For we do know that Insure technique reduces the need for mechanical ventilation, reduces the risk of air leak syndromes, and decreases the risk of death and or bronchopulmonary disease. And if we look at the administration of surfactant with ongoing TPs, what we call that as an Insure, we would just disconnect, give the bolus of surfactant, withdraw, and come back to the TPs and continue to support with means of respiratory breaths being given. So this is one way by which you do Insure to a baby, where you just intubate, get it back onto the TP's resuscitator, administer the dose, and then once the dose is administered, you go back to supplying CPAP. Are there any other ways by which we could modify the Insure techniques? Now, there is a growing body of evidence to say, why do you want to use endotracheal tube for administering surfactant? And one would here use what is called as LISA technique, that is less invasive surfactant. For that, you just need a forceps, a laryngoscope, where you would introduce the feeding tube under vision, and you then administer the dose of surfactant through a feeding tube rather than through an endotracheal tube. So it becomes less invasive. The second option that is you have is what is called as the minimally invasive surfactant therapy, MIST. So this was LISA, less invasive. This is minimally invasive. Again, you need a laryngoscope, you need a catheter. So instead of a feeding tube, you have a flexible catheter. So you intubate, introduce the flexible catheter. Through that flexible catheter, you administer the surfactant and get back the catheter. Now, during both these two techniques, what happens is the baby's respiratory support in the form of CPAP is continuing. So it is not that you discontinue from CPAP and then do it. Unlike here in the Insure technique, where we had to disconnect the baby from the CPAP, administer surfactant, and go back to the CPAP. Here in both the MIST and the LISA, what you have to do is continue with your CPAP and just instead of intubating, introduce either a feeding tube or an angiocath of a spatial nature that will serve the purpose. And this technique has been found to be much superior compared to the Insure technique. However, there is a learning curve which is required, and specific skills need to be developed for acquiring these. And about 20% of the centers so far, to my knowledge, in our country have shifted over. However, there would be units who would be using it now, these as a standard of care. So what have we learned in terms of management of respiratory distress syndrome? As soon as the baby comes, you objectively assess the respiratory score by doing the Silverman-Anderson score. Onset of respiratory distress in the first 6 hours with the score crossing any time beyond 3 or having need for oxygen requirement of 30% or more, you would start with CPAP as your first line of therapy. Now this CPAP can be given as a underwater or bubble CPAP, or it can be given through a variable flow CPAP or through a mechanical ventilator. It doesn't matter. Following initiation of CPAP comes the second stage in the timeline of RDS, and that is you cross a threshold of 40% or you need a CPAP support of 5 or 6 to have the respiratory distress relieved, is the time when you would administer surfactant. Many would do Insure technique, but if you have expertise, you would use LISA or MIST technique at this stage. So about 2/3 of your babies would respond to this form of non-invasive care, provided the mother had received a course of antenatal steroids. However, there would be, if the mother has received a partial course of antenatal steroids or no course of antenatal steroids, you would not get this window of opportunity to provide non-invasive respiratory support, simply because they will end up with severe respiratory distress, requiring higher oxygen, requiring, if at all, a trial of CPAP. And we identified which babies will not benefit from this trial of CPAP and end up with respiratory failure. But these would be indications for providing mechanical ventilation. You would need to intubate and provide respiratory support. The third avenue for respiratory support that we have is, unlike CPAP, a simpler form of, like we have the nasal prong oxygen therapy that we give, a specialized form of prongs, what are called as high flow nasal cannula. And the only difference that you need to keep in mind is unlike the CPAP, the delivery of PEEP with this modality is variable, inconsistent. The prong has to be loosely fitting when it comes to humidified high flow nasal cannula versus CPAP where it has to be snugly fitting. And though many of the units have started using high flow nasal cannula as first line of support, literature does not support high flow nasal cannula as a choice of respiratory care when it comes to managing babies with respiratory distress syndrome. There are two caveats that need to be kept in mind. There are no trials for babies beyond less than 28 weeks of gestation. And second is that high flow nasal cannula is good as a support for post-extubation, either from CPAP or from mechanical ventilation, or as a good strategy while weaning from CPAP, but it is not to be considered as a primary strategy when it comes to supporting babies with RDS as a first-line therapy. If I have to summarize in next two slides, the entire proposition of RDS and how it evolved, giving oxygen alone will not help. Adding CPAP in addition to oxygen will help almost 70% of your babies. If you are able to procure and administer surfactant timely, we would now reach to almost 85% of the babies. And what it means is this care can easily be possible, feasible, provided we follow the standards of care. And therefore, today there has been a paradigm change in terms of management of RDS, for it is now predominantly in the domain of level 2 care, where non-invasive respiratory support with timely intervention of surfactant based on clinical assessment bedside. You don't need an X-ray to make a diagnosis. It's a clinical diagnosis. You don't need an X-ray to even administer surfactant first dose. If you need a second dose, mandatory that you need a X-ray. Hardly an ABG was required so far. And if we are able to perform this properly, we would reach to almost 85% of our preterms. And what is left behind is a very small segment of newborns who would end up with mechanical ventilation. So that's the first key message which emerges from whatever I have said so far. Second, there are 4 interventions that we need to keep in mind. This is what you can say EPIC trial, which happened in Europe across countries in the European continent. And they just identified 4 interventions to help improve the outcome of very preterms. I'm not talking about preterms, very preterms. These 4 interventions were: A, place of delivery; B, antenatal steroids; C, hypothermia management; and D, CPAP with or without surfactant. If we are able to touch in all the 4, and you would be surprised that even in developed countries, it was to a tune of 60% only that they could reach in delivering all the 4 simultaneously, telling us that we are faltering when it comes to providing care on basics and end up with mechanical ventilation, high frequency ventilation, when we have simple interventions which are ignored, underlooked. And therefore I started with what best we could do prior to birth, what best we could do in the delivery room. And if you look at these simple 4 interventions, they are doable in any setup, irrespective of availability of skills or resources. And what does it mean? RDS today has no magic bullet. What starts prior to the delivery room, what we do or what we don't do in the delivery room has a huge impact. Use of non-invasive respiratory support, either in the form of CPAP or a non-invasive ventilation, has today changed the outcome in terms of RDS. Selective early rescue surfactant is the key for optimum respiratory outcomes. But mind you, it is not just the respiratory care which is going to help such newborns. So what we do need is meticulous monitoring, a nutritional support, aggressive infection control strategy, and last but not the least, good teamwork. And that's what makes or breaks the outcome of these babies with respiratory distress syndrome. Thank you so much.
Thank you, Rishi, for a wonderful uh, kind of journey from the delivery room right up to the neonatal unit. And I think you have picked up all the possible areas of intervention, right from temperature control to CPAP and mechanical ventilation. And needless it to say that mechanical ventilation has a very small role to play in an average case. So we'll go through questions. Mm, Dr. Rajesh is asking antenatal steroid guidelines for multiple pregnancies.
Sir, if you see the guidelines which came on use of antenatal steroids, they clearly said that multiple pregnancies, mothers with diabetes, mothers with PROM, mothers with medical disorders would not in any way come in the delivery of antenatal steroids. It is today taken as a standard of care that we would give antenatal steroids for all um, uh, threatened preterm labors, irrespective of the medical reason. What we do know is the second born twin is more at risk for developing RDS compared to the first born. So if you are in the delivery room, my attention is more on the second newborn. But again, look at whether the course of steroid has been given rather than a dose of steroid has been given. Dose will give you some benefit. It is a partial benefit. But if you want a complete benefit, we must give a course of steroids.
You have been using the term threatened preterm delivery. Would you elaborate on that point?
This falls in the obstetric domain. And if you look at the Government of India guidelines, it helps you identify whether it's a true labor or a false labor. And the onset of labor pains, the frequency of labor pains, the site of labor pains, and presence or absence of show makes you realize that whether it is a true labor pains or false labor pains. So based on this, even a peripheral healthcare provider is told how we identify a true preterm labor pain. And that is how they go about in their algorithm about threatened preterm labor.
I have seen a practice of giving antenatal steroid too early in the pregnancy by obstetricians, and then they give many repeated dosage. Uh, what would you say about this practice?
Sir, again, if you look at the evidence, what it tells us is repeated course of steroids today is not a standard of care. B, repeated course of steroids may be detrimental because steroids have been known to cause neurotoxicity. There is, however, no role of giving course of steroids beyond 32 weeks of gestation as a second dose. So if you have, say, a preterm mother who came in threatened labor, and by your conservative care, despite administration, you could tide over the crisis for next 7 days. That means over the next 2 weeks, below 32 weeks of gestation, she comes back again with threatened preterm labor. Then only there is a, what you can say, iota of indication of using a prenatal steroid course. But a repeat course of steroids or an elective or what you said, a rescue course of steroids is not recommended, and is in fact detrimental simply because the steroids, see, we are not concerned about immediate short-term outcomes. The use of all these steroids repeatedly, both in terms of RDS or for in terms of chronic lung disease, outcomes are achieved. So your neurobehavioral outcomes, your cognitive outcomes, they are likely to be suffering from. And therefore, if you look at a cost-benefit ratio, we would not ensure a repeat course of steroids, and we would not give rescue steroids as and when the mother comes.
Is Lisa or MIST being practiced regularly by neonatologists these days?
Yes. It all depends upon, see, it was like this about 10 years back. Would you use CPAP? There is a learning curve. You would fail sometimes. And What it just requires is practice, practice, and practice. And if you want just to have a look, just put Lisa or less invasive surfactant in the YouTube. You will see plethora of videos. Now, if even with those, you would find that intubating, see, there is one big default with all these non-invasive forms of surfactant administration. There is still a need for using a laryngoscope. In a baby, very preterm, less than 28 weeks of gestation, to intubate, you need to be really proficient in terms of your skills. And that is a big drawback. You spend more time in intubation. And again, the fun remains in doing it in a very timely manner. Otherwise, you will end up causing more damage than benefit. There are two more concerns which make it difficult. We do not know what is the protocol for sedation and analgesia, simply because this becomes an elective procedure. This baby is already on nasal CPAP. In addition, we are going to intubate. So the Western units use a sedation and an analgesia along with these. Second, which is the best way, we still don't know. But it is a very, what you can say, interesting, concept, simply because the best way would be to give, not even using a laryngoscope. For there are emerging studies which tell us that probably like a nebulizer, we would be able to give surfactant through a nebulized form. And we have phase 1, phase 2 trials which are already in play. So exciting things are happening in the way by which we administer surfactant. But if you ask me, majority would be doing an Insure technique simply because it is time tested. And if you are good in Insure, why not? You should be able to do Lisa or MIST also.
Rishi, do you have any personal preference for the type of CPAP that you use in your unit, or?
Sir, it's very simple. It all boils down, it's like saying whether I would use a radiant warmer or an incubator for caring for the babies. It all depends upon the skills and expertise, and most important, the user-friendly nature of any equipment which is there in the nursery. For example, in my unit, if I am using bubble CPAP for donkey years, every nurse staff is trained and well versed with application. It becomes very easy in terms of practical utility. And evidence today does suggest that there is a slight edge of using underwater or bubble CPAP over the variable flow CPAP. If you look at cost effectiveness, it's but obvious that your bubble CPAP is much inexpensive compared to your variable flow or a high flow CPAP, which would be requiring a ventilator.
Can we dwell for a minute or so on prevention of nasal trauma when we are using CPAP?
The single most factor which is responsible for nasal trauma is the duration of CPAP. What does it mean? The earlier you get out of CPAP, so in the ideal circumstances, if the mother has received antenatal steroids, you start CPAP early and see if required, give timely surfactant. 48 to 72 hours is the time period when you will be out of your respiratory support. In these circumstances, it's very unlikely that you will end up with any form of local injury. Now, as you enter into the first week or towards the end of first week, the best way would be to have a checklist. So, see, we have to look at few things which has to happen at every time you look at the newborn, as and when you get an opportunity to see. So what is being looked at is A, the prongs are snugly fitting. B, there is no asymmetry. C, there is no erythema or discoloration over the face. D, the prongs have been fixed appropriately. Then the position of the baby is changed every 4 to 6 hours. And most important, electively, this is one situation where you would do routine suction. So every 3 to 4 hours or 4 to 6 hours, based on the clinical status, you would get the prongs out, put a drop of normal saline, do a quick suction, and go back onto the nasal prong. And every time you get the prongs out, apply pressure on the nose and release the pressure. Like we do a CRT, you apply pressure and you release the pressure. What you are looking at is the underlying uniformity of good recalibration which should happen in terms of the vasculature. If while you do this, you find that there is asymmetry or there is no vascular response, it tells you that the pressure of the nasal interface is abating on the face. Now, these simple few every 4 to 6 hour strategies. So best is have a checklist and look at the prong size, look at the prong fixation, look at the application of the interface, see that there is an orogastric tube which is in place, and look for symmetry, coloration, and every 4 to 6 hours do a suction. So it is labor intensive, no doubt, but it is worth putting simply. And there is one more caveat that has to be kept in mind. Unlike any ventilator, if the baby stops breathing, there is no alarm which will happen with this form of CPAP, that is underwater bubble CPAP. The bubbles will continue to be there. So if the staff is sitting there in the central, nursing station, and she's just looking, thinking that the bubbling is happening, so it tells you that the baby is breathing, it is not so. There's no alarm unless you have set an alarm on the pulse oximeter, because the baby will just desaturate. And if you have muted the pulse oximeter alarm, there is no way by which there will be a respiratory support which will happen, and the baby will be found to be in apnea. Unlike a baby who would be on, say, CPAP being delivered by means of a ventilator, where there will be a takeover which will happen. So that is one key concern or one drawback of using an underwater bubble CPAP. There is no alarm system there.
Rishi, one more thought comes to my mind. When you are having a baby who is on mechanical ventilation because of one or the other reasons that you have cited, and the baby improves and is now the time to wean the baby off, what will be your preference, CPAP or high flow nasal cannula? And which method will you use for CPAP?
So it's, we have been going back to underwater bubble CPAP. But today, if you have resources, then better have a high flow nasal cannula, simply because we do know that the utility of high flow nasal cannula compared to CPAP remains the same in terms of efficacy. And more so, the entire jhanjat of having this staff getting every 4 hourly, 2 hourly, looking after that baby goes away when you use a humidified high flow nasal cannula. So that becomes a very attractive option simply because of lesser adverse effects. So I don't see any reason why it will not be as our first line of support for babies being extubated.
And if somebody does not have high flow nasal cannula and has to resort to CPAP as a weaning mode, what would be the best method to give CPAP?
Sir, the best way to give CPAP is you have two options in terms of interface. One option is to use a nasal prong. The second option is to use a mask. So use any of these two. So that's as far as the interface is concerned. As far as the machine is concerned, you have a bubble CPAP, or you have just, if you're on a ventilator, just shift over to the CPAP mode. So, and dial your FiO2 and dial your PEEP. So that becomes very easy if you are on the ventilator. So you don't need a second equipment. You just shift over from one mode to the other mode. And I don't see any much advantage of shifting. If you have a machine which is already there, why do you need a separate underwater bubble CPAP as a second machine to be added on to this baby when you could easily move over from one mode to the other?
Your thoughts on using CPAP via a machine in an intubated baby? The baby will have to breathe.
No, not intubated. No. Endotracheal CPAP is the worst form of CPAP. In fact, the story begins of CPAP way back in the 70s, where they started with endotracheal CPAP. Now, endotracheal CPAP is akin to trying to drink through a straw.
Right.
If I am asked to drink tea through a straw, it will increase my efforts. So it is going to increase your efforts when it comes to endotracheal tube. So what I mean when I say post-extubation support, if you are on a ventilator and the settings are less and you have extubated the baby, so you get rid of the endotracheal tube and now shift over to a nasal form of interface, and you can connect it back with the same tubings to the ventilator. Or if you have an access to underwater and you want the machine to be kept vacant for another baby, then you shift over to So it will be always a nasal form of CPAP always. So either you give by means of a nasal prong or by means of a face mask. It doesn't matter. Neither of them are equivalent.
I had read in the past that in PGI they were using nasopharyngeal endotracheal tube after
Yes.
extubating the baby and giving CPAP. So what's your comment?
Yes. Yeah. So it all started with endotracheal CPAP. We realized it was causing harm. Then some of them shifted over to nasopharyngeal CPAP, and so also for oxygen delivery. Again, more what you can say, increased work of breathing, lesser gains, more side effects. So again, that went out of picture. So today there is only one way by which CPAP has to be administered. It is non-invasive. You do not cross the nasopharynx. You do not cross the oropharynx. You always restrict yourself to the nostrils. As I said, when it comes to CPAP, you use the nostril, means the prongs, which will cover 2/3 of the internal diameter of your nose. So that is your nasal CPAP. But when you use any form of CPAP other than that, say by means of a high flow cannula, there 50% should be the prong in terms of its occlusion of the diameter of the nose. So snugly fitting underwater CPAP, loosely fitting high flow CPAP. So that is how your prongs make a huge difference in terms of application. And again, today we have almost 5 or 6 varieties of prongs which are available in the market. Now it again boils down to how, what you can say, user friendly, or how much your staff is trained to that particular form of nasal prongs. Each of the technique of fixation is different, and therefore the staff has to be well versed. So stick to one technique only rather than make use of different varieties. And today, in addition, at this stage, let me just share another thought. That is, some of the units would not use even a high flow nasal cannula. They would use what is called as the RAMS cannula. And till last year, they were what you can say off-label use. But today, with the RAMS cannula, using a cannula for fixation, this has become what you can say most user-friendly, non-nasal traumatic form of application of CPAP. And now we have evidence also coming to say this is an equally effective way by which CPAP can be administered.
One colleague has expressed concern to the use of surfactant without any radiological evidence, only on clinical grounds, vis-a-vis
Yes.
medico-legal aspect.
Correct. It's very, what you can say, the only reason, A, RDS is needed for a clinical diagnosis. B, if we have this diagnosis in doubt, or if we have a complication setting in, then only an X-ray test is needed. I'm talking about in the first few hours after birth. C, if you are doing an X-ray, the only reason by which you could justify doing an X-ray is to ensure that the endotracheal tube is in place. But I don't need an X-ray to confirm that the endotracheal tube is in place, simply because if you have the vocal cords guide and it's under vision procedure, so it's, and you have confirmed postnatally by looking at different ways and means to ensure that the endotracheal tube is in place. So the only prerequisite for surfactant administration is twofold. A, the baby has to be stabilized. So there's no point having a baby gasping and you intubate and give surfactant. That baby needs to be stabilized. So TOPS, temperature, oxygen, perfusion, sugars have to be addressed before you get onto your further intervention. And the second is that you would definitely be asked for an X-ray if you are going to use a second dose of surfactant. And this is what, simply because now you need to be very clear that you are not dealing with a complication. There are no comorbid features which are coming in the way. And if you read any of the recommendations, none of them would talk about doing an X-ray test routinely prior to administering surfactant. Means it is not unethical, I would say, simply because it is all clinical bound way by which one would go ahead.
Since you are already on second dose of surfactant, could you touch on the indications of second dose of surfactant?
Yes, yes, yes. Uh, 2/3 of your babies would respond to the first dose. Those babies who are not going to respond to the first dose are the ones who either had not received steroids to the mother or received partial course of steroids, or there is a comorbid feature which is there. Congenital pneumonia, a PDA, an IVH, or you have a pulmonary hemorrhage sitting in, or it is not even a RDS diagnosis, or there was something wrong in your dose delivery. That means the dose was not calculated, or the dose was not delivered appropriately, or there was somebody came and quickly did a suction for 2 hours. Nobody is supposed to do a suction following administration of surfactant therapy. So wrong baby, wrong disease, wrong dose are the reasons why surfactant may not work. Having said that, 12 hours down the line, if your oxygen requirement continues to be beyond 50%, many would go ahead and give a second dose of surfactant, or the baby continues to be intubated and the respiratory support does not seem to be decreasing, it is increasing. So in such situation, one would go on to give a second dose of surfactant. Now, again, the and rarely you would need a third dose. But I would say if you don't get a response in your second dose of surfactant, either you change the diagnosis or there is a complication which is sitting.
Somebody wants to know, can laryngeal mask be used to give surfactant?
Yes, yes. When I said less invasive ventilation or less invasive form of surfactant administration, one such strategy is to use a laryngeal mask airway. As of today, if you see the guidelines, the use of laryngeal mask airway is restricted to babies beyond 2 kg and beyond 34 weeks of gestation. So that's one big drawback. But studies have been forthcoming which have started showing that one way by which we can administer surfactant is laryngeal mask airway. But if you see, the only people who have used maximum laryngeal mask airway are the anesthetists. So using a laryngeal mask airway itself again needs a skill that needs to be acquired and needs to be developed, though theoretically tells you that it's a simple bedside procedure, but healthcare providers time and again have been found it to be difficult to use a laryngeal mask airway. So you need to be well versed with that. But that's another option by which you could administer surfactant.
Somebody has raised an issue that steroids after 34 weeks of gestation, there are RCTs to show reduced NICU admissions.
Correct, correct, sir. Deliberately I have put that slide simply because ACOG came out with these guidelines that it would be appearing to be safe for preterms or late preterms beyond 34 weeks of gestation, because they would want even a single baby to go on to develop an RDS. So there is a recommendation which has come. Now, if you read what you can say between the lines, and if you interpret the data, it showed very clearly that it helps you reduce the incidence of transient tachypnea of newborn. So transient tachypnea of newborn is something which is a self-limiting condition, hardly requires any respiratory support or interventions, and is a self-limiting disorder. And number two is many of these newborns ended up with hypoglycemia when we're given postnatal, when we're given steroids beyond 34 weeks of gestation. So what it also means is these babies, in addition, need to be monitored for blood glucose. Now this is a takeoff between cost effectiveness of having that hypoglycemic episode and having an adverse sequelae later on versus reducing the incidence of transient tachypnea of newborn and getting away with the respiratory support. So it's all about looking short term and long term. And those of who are following the scientific literature, yesterday there is a paper which has come in JAMA Pediatrics about use of steroids beyond 34 weeks of gestation. The title is not about that, but the title says that the use of steroids leads to increased neurocognitive and behavioral disturbances in newborns. So this is very, what you can say, startling information, simply because on one hand we thought that it is safe, and the title of this tells you that this is associated with significant long-term adverse sequelae. But if you read it carefully, The subgroup which was identified to have developed these long-term problems were those beyond 34 weeks of gestation and term newborns who electively underwent LSES thinking that they should not develop RDS, they gave a course of steroids. And that is in these two subset of population were the ones which ended up with. So today it is a, what you can say, standard of care that will demand that restrict to time tested less than 34 weeks of gestation till we have long-term data to say that it is safe and effective. Otherwise, yesterday's paper would be an eye-opener for all those who have been using more than 34 weeks of gestation prenatal steroids.
Two colleagues have referred to European consensus guidelines for RDS. So would you briefly touch upon the highlight point of this European guideline?
Let me again, the European guidelines came in 2010, then came back in 2016, I think 15 or 16, and then 2019, the third version came. Now, if you want to be updated, I would say use country-specific guidelines. Now, that is simply because some of the things which work there, like for example, if you see those babies which I showed you in the studies, the point trial, the support trial, and all of those, their use of antenatal steroids has been more than 90%. Our national average hardly touches 60%. And even in best of setups, we are still struggling to use antenatal steroids to our best ability. And therefore, the entire science becomes, what you can say, haywire if you try to amalgamate that strategy here. So if you want to be updated on the use of what you can say surfactant or for that matter RDS management, I would suggest please go through the document by National Neonatology Forum. This January, the clinical practice guidelines, way back after 2011, the second edition has come. They are free for download. Almost, if you go to the NNF website, just nnfi.org/CPG, almost half a dozen of the guidelines which are up to date, India specific, have been displayed. And I would suggest those to be followed. If you ask me between the European guidelines and the current strategy, what is the major difference that I have not covered? The first is that they would say at 5 minutes of life, the delivery room minute specific oxygen saturation has to be more than 80%. So that is one clinical marker that has to be noted, which again is a good predictor for long-term outcomes. So that's one. As far as the strategy of CPAP is concerned, there is not much of a difference. As far as the use of surfactant is concerned, again, they don't promote use of prophylactic surfactant, but they, yes, have a threshold. I have given a threshold of 0.4, 40%. They use a threshold of 30%. Now, 30% and 40% is a, what you can say, I would give a doubt for CPAP to work rather than try to avoid another expensive therapy. If it works, well and good, but they would be giving surfactant at 30%. The third strategy they have added in addition is anybody who goes on to CPAP, they would start caffeine. So caffeine is an early intervention that has been specifically mentioned, which I have not mentioned simply because I thought I will focus more on RDS, but more importantly, I'm not a firm believer of prophylactic therapies in newborn. If you look at the Cochrane review, right from as a postgraduate and thereafter during my studies, thereafter, anything which came as prophylactic IVIG, prophylactic kinesthetic stimulation, prophylactic CPAP, prophylactic surfactant, prophylactic antibiotics, then you have prophylactic theophylline, prophylactic, all of these interventions came in a big way, but ended up nowhere 5 years, 10 years down the line, simply because the more you intervene in the newborn, the more is the likely risk that you will end up with some problem or the other. So would you want prophylactic xanthine, caffeine to be given to all? Yes, definitely if the baby is less than 28 weeks of gestation. But you want it to be given for babies at 32 and 34 weeks of gestation? I would not say that this would be a good science to practice.
And the last question, how quickly do you visualize the effect of surfactant coming in after administration?
okay, the dose of surfactant is 100 mg per kg. This dose usually is given in 4 different aliquots, one after the other. So the moment you give the first aliquot, you wait for 30 seconds to 1 minute as you stabilize the baby. So you look at the work of breathing, you look at the chest retractions, you look at the color, you look at the breath sounds, and you look at the SpO2. Once that is stable, you give the second dose, then you give, again wait for some time, give the third dose. So roughly anywhere from 2 to 5 minutes is the course by which the delivery of the drug takes over. Now, how long will you wait for the action to be seen? I would wait so this is just administration of surfactant, and this is half the job done. The real job begins thereafter, simply because the lungs will now get expanded, the air entry will improve, and this is the time for next 1 hour. You should not leave the baby under any cost. You need to sit there, titrate the FiO2, titrate the PEEP, and based on these, come down one after the other, so that the weaning starts right there based on the clinical response that the baby gives. So it is in the first 1 hour. Surfactant administration is just half the job done, but the complete job gets done 1 hour down the line as you clinically monitor and adjust your supplementation.
Thank you, Rishi. It's time to thank you profusely for a wonderful, wonderful deliberation. Looking at the chat box, I could see how many colleagues have appreciated your deliberation. And it's a wonderful media to interact. I was just looking at the time. After 45 minutes of your talk, we had 28 minutes of interaction. So this is a luxury we never had in a conventional conference, where all the questions are being postponed to a lunch interval. So I think it's wonderful interaction of 28 minutes after a wonderful talk of 45 minutes. So,
but I think there is a lot of learning which happens here, and what I learned over the so many seminars that you have conducted is, I wish I continue to have that zeal and enthusiasm like you to keep on learning and keep eyes and ears open, simply because you are a living example of how a teacher and a student is always.
Thank you, Rishi, for your kind remarks. And we really love to have you on the board, and we would again use your expertise and your skills sometimes later. So a wonderful talk, and extremely thankful from the awesome group. Thank you, Rishi.
Thank you so much, sir. Thank you so much.